In this second session, I want to talk about some areas of application of ICTs in the health sector. While I go through the different areas, I'd like you to remember that I said that ICT innovations can either reform or transform health systems. So by reform, I mean that you do things better within the existing system through technical innovation, improving communications, improving the way in which we keep track of drugs, staff, payments, and so on and so forth, improving efficiency, improving the quality of services. By transformation, I mean that we might do different things. So changing the ways in which people access health knowledge, shifting power relations between providers of services and patients, shifting power relations between different kinds of providers, between doctors and pharmacists, for example. The four areas I'm going to address are health management information systems, the kind of flow of data around the health system. Then I'm going to look at what I call a command and control healthcare system, running your healthcare system using computers. Then I'll have a look at the idea of telemedicine, and then the big area and very diffuse area of public access to health information. So the first area I'm going to look at is health management information systems. And I'm going to look at a rather ancient intervention in Uganda. Ancient, but very similar to many exercises which have been undertaken since then. Really the only thing that's changed is the technology. The objectives and basic approach is very similar across those interventions. So this was one which was set up by an NGO called Satterlife in Canada, funded by IDRC and in collaboration with Makerere University. The basic idea was to improve the data collection exercises undertaken by the Ministry of Health by providing the health personnel, the field workers, with what were then called personal data assistants. So these are essentially smartphones, though some are still called PDAs. So 200 of these given to individual health workers who then went out and collected basic health information in 2 districts. So the basic idea was that they would simply use the PDAs to collect exactly the same data that they had previously collected on paper forms. So this was the routine MOH data system, and they were just replacing the paper with PDAs. Once they'd collected the information, which was stored on the PDAs, they could then upload it to a series of 20 connection points which are scattered around the district. So they would take their PDAs to one of these points and press a few buttons and upload the data that they'd collected. When they were uploading data, or during that period, they could also receive information from the ministry telling them what the plans were for the next month, maybe providing some online training, new protocols that were being introduced, and information about what looked like potential disease outbreaks in their district. Quite importantly, they were also provided with email facilities, important in that this was intended for use for them to link up with the ministry. But of course it also enabled them to link up with their friends anywhere else in Uganda or indeed around the world. And its main function, it turned out, was to make the system attractive to the field workers. Well, an advantage of looking at a project which has been around for a long time is that there's quite a lot of information assessing the benefits of this system and the costs over a long period of time. And there were substantial benefits. It's been found that, for example, there were considerable improvements in the compliance rates on the reporting of notifiable diseases within the districts. In fact, there was a 100% compliance rate compared to the 63% level, which had previously been estimated. Perhaps most importantly, there was a high level of satisfaction among the health workers. They now felt as though their job had been upgraded. They now felt much more like professional workers, rather than people who were scribbling notes on pieces of paper in the field and being disregarded. They also very much appreciated the email service provided by the system. General impression from the assessments was that these were much happier workers, and that reflected on the quality of data they were providing and the completeness of the data they were providing. So a general improvement in the overall data collection system. Unfortunately, of course, there were cost implications. It was found that this cost about 3 times as much as the previous paper-based system to run, mainly because of the need to employ people who could fix problems with the system. They had to run a service using qualified people to sort out any problems arising from the use of the PDAs, problems with the transmission systems and so on and so forth, and also costs of using the mobile phone telephone network, which is being used to transmit the information to the Ministry of Health. So it was 3 times as expensive, and Satterlife argued, well, this was maybe a reasonable price to pay. It still wasn't that costly. Unfortunately, if you translate that into the percentage of the total health budget for Uganda at that time, it turned out to be about 3 to 4% of the total budget. 3 to 4% again, is that a lot? Well, when you think that almost the entire budget goes on salaries and drugs, yes, it is. For example, the total maintenance budget was probably about 1% of the overall health budget. So it looks manageable, but in fact there is a high risk of switching to this system, which was recognized by the Ministry of Health, because if there were cost pressures on the ministry, this would be a natural target. The ministry was not going to cut back on its personnel costs, it was not going to cut back on its drug costs, but it might well cut back on the costs of running its data collection system. And it was not possible to revert easily from the PDA system to a paper-based system. So there was a high risk if you switched over to the new system, which was 3 times as expensive, that you might run into a situation where there was simply no money to collect data in a given year, and therefore you would have no data to run a health service. So there were serious issues around the potential sustainability of this ICT system. So some of the issues that we might raise in general, well, poor health management information systems is often recognized as a key problem in health systems management. You don't know what's going on, and therefore you don't know how to plan for what should happen next. Especially in remote areas of the country, very little information being provided. So this is a potentially very useful activity to undertake. This was a small-scale pilot, and it was very closely supervised by satellite. With many of these pilots, we have grave doubts that the full cost implications are actually addressed. NGOs tend to have people who tend to give up quite a lot of their time and don't actually cost that time. So we don't really know the cost side. The estimate was 3 times as much as the paper-based system. It may well have been considerably more than that. With that close supervision, there were a lot of unplanned expenditures at the early stage of the projects. So they almost immediately had to upgrade the hardware. The communication points had to be replaced to improve communications links. They just didn't work adequately. They couldn't handle the volume of data which was being required of them, even though there had obviously been an assessment of how this would work before the project started. They also discovered, again, you might have expected this to have been addressed more adequately in the planning stage, that they couldn't actually deal with the complexity of the MOH forms. So they had to rewrite the software which went on the PDAs to handle the more complex MOH forms. And then they had enormous problems with recharging the batteries on the PDAs, and had to introduce lots of new approaches, experimental approaches, essentially motorcycles with batteries, solar panels, and so on and so forth, to keep the PDAs running. Even though they'd planned, they thought fairly carefully, they ran into a lot of unexpected costs fairly early in the project. Well, this is very, very typical of ICT interventions. Do a lot of planning, a lot of testing. You bring in the hardware people and the software people to carefully design the new system. You run tests, which all prove to be eventually successful, and then you launch the intervention at scale, in this case in 2 districts, and you discover that nothing seems to work. And so you have to put a lot more money in to replace the hardware, replace the software. In the NHS in the UK, huge amounts of money have been invested. Projects have followed a very, very similar pattern, and in some cases eventually been abandoned because of cost overruns. The next area I want to look at is what I've called the command and control area, where you try to use computers to improve the management and therefore the efficiency of your health service. What I'm going to use is a computer-based primary healthcare initiative in South Africa. It's interesting because it was set up by a private provider, in fact the largest private provider of clinic services in urban areas of South Africa. What it offered was ambulatory care, i.e. people coming to the clinic with a certain range of ailments could pay a flat fee of about $7 for treatment, irrespective of the specific condition that they were suffering from. And the company running the system also offered this to companies in urban areas who could take out insurance to cover their staff. So a reasonable portion of those coming to the clinic were actually covered by employment insurance. Each clinic was linked to a central computer server system that not only handled the management and the financial affairs of the clinics, but also essentially managed their clinical operations and looked after their clinical data. The basic mode of operation of the clinic was that there was a hierarchy of carers, each with a computer by their side, so that when a patient appeared at the door of the clinic, there would be literally a gatekeeper who would have a computer and would take some basic details from the patient and then decide if they were the kind of person who should be sent to the nurse or sent away, maybe sent off to hospital. Maybe they couldn't afford to pay the $7, maybe they weren't insured when they thought they were insured, and so on and so forth. So the ancillary worker would be there to provide a gateway to the nurse, who was the second level in the hierarchy. When they went to see the nurse would again take their details and take their symptoms, feed the symptoms into the computer, and the computer would basically tell the nurse what to do with the patient. Well, three things they might do. One is to tell them, sorry, we can't help you, here's your $7 back, go away. Or go and see the pharmacist, here's a prescription for some paracetamol or whatever for your headache. Or they might say, well, I think you should go and see the doctor. Well, off they would troop to the doctor. Doctor would feed some more information into the computer would come back and tell the doctor what they should do with the patient. Again, this might be, well, I'm sorry, we can't really help you here because your symptoms are too complicated and you don't match our requirements, so we suggest you go to the hospital. Or the doctor might write them a prescription and off they would go to the pharmacy. What were the computers actually doing? Well, the clinic was covering only a fairly limited range of conditions for which there are fairly well established best practice protocols. These usually derive from something called the Cochrane Collaboration, which has a very large database of best practice. Once the symptoms had been fed into the computer, it could assess what was the most likely diagnosis and then use the best practice protocols to decide what prescription should be given. Well, what can we say about this system? Well, interestingly, there was an independent assessment by the London School of Hygiene and Tropical Medicine, and they were favourably impressed by the quality of the services provided. They were at least as good as other clinics in the urban areas. There was a high level of satisfaction among the patients. They were very happy with the fact that they knew exactly what their treatment was going to cost, and they had considerable trust in the quality of the services that were being provided. There are a couple of downsides to this approach which people might think about. One is that this clinic is engaging in what we generally refer to as cherry picking. It's taking those cases which can be relatively easily diagnosed and treated, and each patient is required to deliver some degree of profit to the clinic which is providing the services. Now, in many health systems there is an element of cross-subsidy whereby the profits, if you like, made on the easy cases tend to offset losses made on more complex cases. If you take away a large element of the profitable cases, the easy cases, then you place a burden on whatever facility is expected to deal with the more difficult cases, and maybe the cost of treating the more difficult cases has to go up. In particular here you might think of the public sector picking up the burden of the more difficult cases and the cases which cost most to treat. Another concern here might be that we are de-skilling the professional staff, de-professionalizing the staff, so that all the providers are expected to follow the recommended treatment. They're allowed to act against the decisions reached by the computer, but then if they contradict the computer, that is noted by, as it were, central office, and the doctor or nurse in question has to explain themselves. Now that puts a lot of pressure on them to go along, obviously, with the computer diagnosis and prescription. And it's an interesting question as to whether doctors and nurses are happy to go along with that kind of restriction on their freedom of diagnosis and prescription. Many doctors and nurses would see this as a lowering of their professional status. They become simply the employees doing what they're told by a computer. It has considerable effects on efficiency, in fact. The staff costs are less than half those in comparable clinics, and the drug costs were about 1/4 of those in those same clinics. So there are considerable efficiencies here, because the doctors share their workload with nurses who are paid much less, and the system more or less eliminates the overprescription of drugs which is commonplace in most private healthcare facilities. The third broad area I'd like to discuss is telemedicine. Now, there are various definitions of telemedicine, and it's been used to cover a very diverse range of activities, but here I'm going to limit my use of the term to links between providers, one provider talking to another, or between providers and specific patients, so a doctor talking to his patients, or a patient talking to their doctor. By far the most important advance has been the simple use of mobile phones, or as it's sometimes put, voice over mobile phones. Patients being able to call the doctor when they need assistance, doctors being able to ring up their patients and check that they're doing what they're supposed to be doing, and that they're taking their medicine and so on and so forth. So not much discussed because it's not very interesting for researchers, but just being able to communicate and using mobile phones is almost certainly had the biggest impact on healthcare as a result of the introduction of ICTs. Then we can think about, then there are a range of more formal patient-provider links. There are various ways in which you can use mobile phone monitoring. So patients with a long-term condition, for example, who are on medication, the doctor can have arrangements whereby they can check when patients are taking their medication. They can perhaps get feedback on self-monitoring of patients using gadgets to measure blood pressure or blood glucose levels and so on. There are so-called alert systems whereby you can, particularly useful for the elderly, press a button and a message goes, "I am in trouble, come and rescue me." And mobile technology can also be used to encourage compliance with treatment regimes. A lot of these developed during the treatment of HIV/AIDS patients, so that, for example, the computer in the clinic can send out reminder messages at certain times of day. Have you taken your tablets yet? More sophisticated, you can have pillboxes which send a message when they're opened, so that a record of at least when the patient has opened the pillbox, even though it doesn't actually obviously detect if they've taken the pills, can be sent. If the box isn't opened, then the clinic can get in contact with the patient and say, what's happening? Is there a problem? Why aren't you taking your medicine? ICT can also provide useful ways of provider-to-provider communications. So that, for example, one interesting finding was that the Grameen Healthline in Bangladesh was used very much by village doctors. These are unqualified doctors who deal with most healthcare problems in Bangladesh, and they were using the Healthline to check with qualified doctors who are on the other end of the Healthline how they should treat a particular kind of condition with which they were not so familiar. There's now an enormous range of distance learning materials available, either downloadable onto your mobile phone or available over the internet if you have access. So these include training videos, manuals, standard reference books, journal articles and so on, often targeted at people such as community health workers. There are also many examples of hospital-to-hospital communications, for example, allowing remote consultations between providers in two locations, so they can jointly review case notes, go through video conferencing processes, exchange X-ray images, ultrasound scans and so on. And these can be national. For example, I work quite a lot in China, and there are links from city hospitals to rural hospitals in many provinces. Or it might be international. For example, there's a link between Moorfields Eye Hospital in London and a number of sub-Saharan African countries to compare notes on particular eye conditions. There are a number of issues around the provision of telemedicine services. For example, it's been found in a number of cases that simply supplying a consultation service doesn't necessarily mean that anybody will use it. There's an interesting example of something called the Ptolemy project, which was aimed at providing advice to surgeons in southern Africa using consultants from various London hospitals. And in fact, very little use was eventually made of that essentially free service. And it would seem that although there was initial enthusiasm for that project, the trouble was that unless these initiatives are integrated into the routine practice of both sets of providers, then they tend to be rather haphazard, and interest falls away over time. A more serious problem is that there has to be a considerable awareness on the part of those providing support that they can't assume what kind of facilities are available in the location that they're supposedly assisting, so that they may be accustomed to advocating what we might call best practice protocols, but that may assume high quality, well-resourced healthcare services. So there's very little point advising that somebody needs an ultrasound scan if the nearest ultrasound scan is 500 miles away in the capital city. Many doctors and consultants are very loath to advocate what they would describe as second best services. They feel it is their professional duty to maintain standards and therefore find it very difficult to adjust to advocating things which they would not do themselves, even though that may be the best possible alternative given the circumstances of the people having to deal with the particular problem that they're advising on. Third issue is that a lot of the interventions that you read about are actually very small-scale exercises, and they often link developed, less developed areas of a country, and a lot of it is on the basis of goodwill. It's people who want to be helpful, providing assistance. They will often provide lots of free time, so a lot of these services are set up on an informal basis with a lot of cross-subsidy, a lot of input of time by well-qualified people who are very well-intentioned and simply want to help. That's okay, but it only works at the small scale. Once you try to scale that up, you suddenly realize that there are a lot of unconsidered costs involved that you didn't bargain on, and therefore the whole operation becomes unsustainable when you try to scale it up. Fourth problem I would raise is that who should provide telemedicine services? There are lots of people in this area. Governments, of course, are one of the key players. The government of Bangladesh, for example, through the Ministry of Health, now provides a teleconsultation service of its own, whereby you can contact a hospital doctor using a free mobile phone number. As I mentioned before, there are lots of health professionals, hospital consultants and so on, who become involved in these kind of activities, supporting their colleagues in less well-served areas. The donors are involved in this area as well. DFID, Gates and so on are involved in the provision of such services. And then, of course, there are lots of national and international private healthcare companies who are also involved in the telemedicine area. Here one wonders on what basis they're doing this. Is it a public relations exercise? Is it going to be profitable? For what sections of the population would it be profitable? Are they going to put their own services through this telemedicine network? Are they going to advise that providers buy their equipment or buy their drugs and so on? And then, of course, there are the drug companies themselves, and the telecoms companies, a lot of whom have become involved in this area for a while. But there is a problem of sustainability, because I think it's fair to say that where we are dealing with relatively poor populations, I don't think there's an example of a cost-effective or profitable way of running these services that has been devised as yet, though a lot of companies have tried. Finally, I'd like to look at the most complex area of application of ICTs, which is around public access to health information. We've mentioned one aspect of this before, that there are now lots of mobile phone teleconsultation services available in different countries. Spoken about the Grameen Health Line, which provides advice from qualified doctors in Dhaka. But there are similar operations in India, for example. Meridoctor and Mediphone both provide advice, and will also, for patients who are registered with them, provide SMS prescriptions over the mobile phone line. There are usually fairly strict regulations around who can prescribe and to whom in different countries, and in most countries you have to be a registered patient of a doctor to get a prescription from that doctor. And this is one of the issues that many teleconsultation services have encountered. Then, if you've got internet access, the world is your oyster in terms of health advice. For example, you can visit a national advice service like UK NHS Direct, which will provide you with advice on whether your symptoms look to be mild or serious, and will tell you to go and see a doctor or take an aspirin and go to bed. There are lots of NGOs who have their sites. For example, I mentioned the East African Health Information Project, which is essentially to provide advice to young people in East Africa on health issues. Or you can go to the private companies. There's a site called Pfizer Helpful Answers, which will again help you to assess your symptoms and come up with a potential diagnosis and advise you whether to go to see a doctor or not. But it may also suggest that you take some medicine, and obviously you should probably take Pfizer medicine because that's probably the best for you. At the extreme end of this, and thankfully it has disappeared, or at least it's disappeared with its original name, there was a site called Dr. Robot. Dr. Robot would take your symptoms and give you a diagnosis and refer you to an online pharmacy. Dr. Robot was actually run out of somewhere in Russia, and the pharmacy was apparently run by his brother. And the quality of the diagnosis and the quality of the treatment recommended can be left to your imagination. If you want to consult the journals, the medical reference texts, it's all there online. And just as people used to use the medical dictionary in the UK, now again you can access whatever reference material you wish online. A lot of it's freely available, some with a subscription charge, but often pirated and hosted somewhere else. Or you might want to join up with one of the many patient groups that have online sites. I've listed some of them here, but there are multiple sites on HIV and AIDS, on stroke, on heart disease, on asthma. You think of a condition and there will almost certainly be an internet site devoted to you. And these are apparently set up by patient groups, though they may be funded by a pharmacy company or they may be supported by a healthcare company, and there's no way of telling. So there's a lot of information out there, a lot of support, a lot of advice available to you. Patients can use this advice to negotiate treatment with their doctor. They can say, well, I went onto this site and it said, or it suggested that this alternative approach might be better or whatever. Or they may go off and treat themselves, because there are also a vast range of prescription and non-prescription drugs available from suppliers over the internet, and send it through the mail to you as long as you pay with your credit card. So I've given one of the rogue sites here, and I trust you won't make use of it. Again, we can ask, what are the main issues around this area? For one thing, in most countries, in previous times, there was something we can call gatekeeping, access to medical information via people who are qualified to provide that information. Now, gatekeeping is more or less impossible, so anybody can become anything they wish on the internet. They can adopt fake qualifications, they can invent evidence, they can extract bits from journals that, out of context, give totally incorrect interpretations. They can conceal their identity, they can be in countries which have no regulation over healthcare provision and so on. So you have no idea really who you're dealing with. Quite common for people just to pretend to be, Johns Hopkins Medical University or whatever, in order to sell materials or lead you in a particular direction. I think that's a particular problem when we are dealing with poorly regulated, multiple provider, largely private transaction health systems. In a country like the UK, if I read things online, I can always go and talk to my doctor about them. So in countries where a consultation with a trustworthy provider is possible, then there's, I think, less of a hazard. Where you don't have that option, where there are no qualified providers around, then it's much less likely that you'll be able to check the information you're getting through the internet or on your mobile phone with anybody who is trustworthy. There will also probably be, in that situation, very few enforced regulations or restrictions on dangerous treatments, on dangerous drugs, on dangerous procedures. So you may, unfortunately, be able to put into practice the advice you've been getting over the internet. I think there is an issue about whether the internet, in terms of provision of health advice, involves a qualitative or quantitative change. Throughout history, there have always been people who we generically call quacks. We call people quacks until we bring them inside the medical net, and then we call them something else. I think the extent of the change with the arrival of the internet is so great that we can think of it as a qualitative change in the way in which health advice is provided and the way in which health knowledge flows. It's on such a scale that I think we're not simply talking about an incremental process. We're thinking about a radical step change in the way things are happening. And that raises very difficult questions about who will mediate access to all this information. In a country like the UK, we assume that the Ministry of Health and health professionals will provide good mediation services, will let us know you shouldn't go there, you shouldn't listen to that person, and so on and so forth. Now, a lot of people have to some extent lost trust in the Ministry of Health and in health professionals, partly because of maybe bad behaviour on the part of some of those health professionals, partly under pressure from commercial organisations who deliberately try to undermine government regulators, health professionals. So it's become much less clear that the majority of populations in many countries place complete faith in their health professionals. Then there are obviously government agencies, either at central level or local government, and again, if they're run by the other political party than the one you support, if you think that they're all corrupt officials who are only out to feather their own nests, then you may not be happy with them as mediators. There are a lot of NGOs and CBOs out there, and some of them are wonderful and some of them are totally corrupt. Just as on the internet, it's very hard to tell whether somebody has set up a CBO in order to profit themselves or for the good of their community. So sometimes you might want to turn to what I'll call community leaders, people who are trusted within the community or have special status within the community. In some cases that may be fine, in other cases it may be that these are largely self-appointed people who have risen to their current position by various dubious means and have ulterior motives for the kind of advice that they're giving. And then we can think about, well, there are lots of patient self-help groups now, people getting together and supporting themselves, participation in action. But again, very hard to tell what is a genuine self-help group of well-intentioned people coming together to support each other in their time of need, and which groups are funded by pharmaceutical companies, by private healthcare interests, or maybe in some cases by, for example, religious groups who to push services in a particular direction. Overall, we're living in a world where trust is a very slippery commodity, where knowing who can mediate access to this wonderful variety of sources of health information has become increasingly problematic.